Hello, everyone, and welcome to the very first official episode of MedicAlert Moments That Matter. I'm Anneliese Pittman, or just Annie, and hopefully you are just as excited as I am for what we have in store for this episode. If you've already listened to our prologue, you'll know it answers some of the big questions about why MedicAlert are making a podcast, who MedicAlert even are, and finally, and perhaps most importantly, who I am and how I ended up behind the microphone. If you haven't had the chance yet, I recommend going back and having a listen. Now that you are hopefully all caught up, let's talk about why episode 1 is so important and also tell you a little bit more about my planning plight. I don't know if any of you have ever found yourself in the situation where you were launching a podcast, maybe an interview of some sorts perhaps, but in the early planning days, there are a lot of details to figure out. What the cover art should look like, what the title should be, what equipment to use, what themes we'll want to cover, and of course, the big one, who are the guests going to be? The moment I started thinking about guests, I had this sense of dread creep over me. Not the bad kind, but the this is a really important decision kind of dread. I realized how important the first guest was, having to effectively set the entire tone of the podcast. So, yes, there was absolutely no pressure choosing the very first guest whatsoever. As I sat there with my growing list of episode themes, story ideas, and all the things I wanted this podcast to become, I had an epiphany. I wanted to interview someone who our members may already be familiar with, someone who isn't too shy behind a camera or microphone, someone who understands emergencies, chronic conditions, the realities of navigating complex health needs, someone who can explain medical concepts and jargon in a way that makes sense, and perhaps most importantly, someone who sees firsthand why having accurate medical information accessible in an emergency can change everything. She graduated as a doctor in 2008 from Flinders University and went on to complete specialist training in immunology and allergy, becoming a member of the Royal College of Physicians in 2017. She has presented at national conferences for immunology, allergy, and rheumatology, and continues active research in allergy and autoimmunity. As the Medical Director of MedicAlert Foundation Australia, she provides clinical oversight and guidance to our member services team and the rest of the foundation to ensure that we maintain high clinical standards. We spoke for just over an hour, tucked away in one of the quiet rooms at our head office in Hindmarsh, just outside of the Adelaide CBD. During our conversation, we discussed the myths and misconceptions surrounding allergies and other common medical conditions, including situations that are often overlooked. She also explained who may benefit from a MedicAlert, why it can be important, and how the technology works, including QR codes and digital access to medical information, before introducing our new member cards featuring NFC technology. And so, without further ado, it is my absolute pleasure to introduce Dr. Caroline Foreman, who joins us for MedicAlert Moments That Matter, Episode 1. Do I need a MedicAlert? So my first question is allergy versus immunology. What's the difference?
Okay, so allergy and immunology are both about the immune system. And allergy is a time when the immune system goes wrong in a very specific way, and immunology can encompass when the immune system goes wrong in many ways. So it could be immune deficiency, so not enough of a part of the immune system, or immune autoimmunity, when you've got too much of the immune system, or it's attacking itself.
Oh,
so
interesting.
Auto is self, and immunity, obviously, so against the self.
against the self.
Yeah.
So what led you down the path that you set on with your medical journey?
Yeah, so I'm a immunology and allergy specialist,
Yes.
and I thought immunology was really interesting when I studied it in basic science before I did my postgraduate medicine. And the reason I liked it was because it seemed so organized and structured and it seems so logical, which I've since discovered it's actually huge, and it just since I started learning about it, there's been so many more developments in it. But I liked it from the beginning, and I liked how antibodies and B cells did helped with bacteria, and I liked how T cells helped with viruses. But then when I went to study medicine, I started to see immunology in all different fields. So every single specialty that I looked into or went through, like in the gut, in the brain, in the sinuses, in the heart, in the lungs, all of it, some parts of problems will be related to the immune system not working properly.
So when you sort of knew that you wanted to study medicine, was that something you had considered, or did you actually have your heart set on any other specialties?
No, I knew I didn't want to be a surgeon because I don't really like cutting things open, and I really like people. So I like talking to people and figuring out what's going on in their lives. And the science made me focus on the immune system part of the person. And now that I've got into private practice, then I can see how they work together.
Do you think that there's any particular demographics where people might not think that they need a medical alert, but maybe they should be looking into it?
Ooh. Um, when people think about MedicAlerts, they'll often think about the very urgent, immediately necessary stuff. So, and that's where it's sort of begun. So, having the ID on the wrist, and the ID will say something that needs immediate attention. So, people with diabetes and low sugar, or people with a blood thinner and they have a bleeding risk, or people with a food allergy or a bee sting allergy. And if someone finds them collapsed, then they will look for an adrenaline. So that's where people immediately go to, I find, when they think of MedicAlert. And then there's people who have something that's a bit unusual or could be very complex. So
Right.
yeah, so the unusual stuff might be like, and there's some conditions like hereditary angioedema, which is quite rare, and it will cause symptoms that look a lot like anaphylaxis, but the
But it's
treatment's
not.
different. That's right. So those people would need a MedicAlert because if someone found them in an emergency, they might think, oh, this person needs adrenaline, and that won't
But
work.
that's not the case.
Exactly.
So, are there any conditions that people don't realize could be incredibly severe and time or treatment could be really important or really different based on what condition they actually have?
Yeah, so there's obviously the hereditary angioedema. People who have pseudo seizures might have a something that looks like a seizure, and the medication that would be used to treat it would be completely different from if they were having a seizure. And often the plan is more about comfort and reassurance to the person rather than giving them a medicine to stop the seizure. So that's something else. And then another condition is, I alluded to before, so bee sting or any sting anaphylaxis. So deaths that occur from bee sting anaphylaxis will often occur in the same demographic or the same people who look the same as who have heart attacks. So men
So
in
the
their
symptoms mimic each other.
yes, because a bee sting anaphylaxis is collapse, and it might be collapse on a farm, like a farmer on a machinery, and they've collapsed on the ground. And often it's men, and they might not have taken that good care of themselves, and so people think, oh, they've had a heart attack. But if they've had a bee sting anaphylaxis, you might be able to treat straight away with adrenaline, and then you can save their lives by giving them the adrenaline straight away because of just a low blood pressure. Whereas if they have a heart disease and are having a heart attack, obviously they need a lot more complex treatment. And some of that might include adrenaline, but also stuff to treat the artery. So if they're wearing that MedicAlert, then you'll be able to see bee sting anaphylaxis. You might be able to look at that action plan, and you'll be able to give the right treatment. And ambulance officers would carry adrenaline with them, and hopefully the person would be carrying adrenaline with them too.
So, are there any medications that seem harmless but change how someone is treated in an emergency?
So, a lot of people are on beta blockers for heart disease, and they might not even know that they're in the class of called beta blockers. But if that person were to have anaphylaxis, whether that's to a bee sting or food allergy or a drug, usually they should be treated with adrenaline, but adrenaline might not work because beta blockers don't work with adrenaline. Beta blockers stop adrenaline working.
When they're used in combination with one another.
That's right, yeah.
And pivoting back, sort of towards more the allergy field, I just wanted to dig deeper because I think that that's an area where there's a lot of confusion for people. Are there any big myths about allergies that you wish people would stop believing?
Yeah, so allergy is actually a lot more simple than people think. So I often get people in my clinic who come to me and say, oh, I'm having an allergic reaction to milk. And then they tell me, and it's that they'll get bloating and diarrhea. And that's actually quite a simple thing. So that's probably lactose intolerance. But other people say, oh, I get bloating and diarrhea with gluten, or bloating and diarrhea with lots of other different foods. And unfortunately, those are not allergies. They can't be picked up on my skin tests or the skin tests that allergy specialists do. And so the allergies are pretty simple. Like the food allergy, it's really can look like breathing difficulty, swelling, lip swelling, facial swelling, rashes, and then if it's very severe, then collapse as well.
Right, so is there actually a difference between allergy intolerances and sensitivities?
Yeah, absolutely. So an allergy is a very specific immune response, and typically that's with the rash and swelling and low blood pressure, whereas an intolerance can be many different things and usually is specific to the person. So their intolerance might be, it might be also dose related. So that person
In terms of like how much of something they've consumed.
That's it, yeah. So someone might be able to have one piece of bread every 2 weeks, whereas if they ate a piece of bread every day, then their tummy might get more upset. And so that's an intolerance, but it's dependent on how much is eaten.
How much is eaten, sure.
Yeah.
Are allergies able to develop later in life, even if someone has never expressed any symptoms before? Or can allergies also sort of be grown out of if someone had an allergy in childhood and then as they move sort of into teenagerhood or adulthood and that allergy sort of seems to go down?
Yeah, absolutely, both of those things. So one of my colleagues used to say, we're not born with allergies, we develop them. And we often see that sometimes people from a different culture will move to Australia, they'll start eating a Western diet, and they're more likely to develop food allergies, but also just because of the Western diet and the environment, they're more likely to develop hay fever from having moved and just because of their background and their genetics. Whereas something like in terms of food allergy and outgrowing it, something like cow's milk allergy and wheat allergy, very commonly outgrown.
Oh, so they can be outgrown.
Absolutely, yeah.
And so when it comes to anaphylaxis, is it always obvious that there's a very severe case, or can it start showing more subtly?
It can start more subtly. It can develop from the milder symptoms, which can be rashes and facial swelling, and then breathing difficulty and collapse. So it can go in that order. It doesn't always, and sometimes people will just develop the very severe symptoms straight away.
Oh, straight away, like with an
right.
allergy, like say to a bee sting.
That's right. So often that will happen that they're stung, and rather than getting a rash or swelling, they don't get any of that and they just collapse. So it looks very much like the heart attack. But in cases of food allergy, and possibly because it's ingested and then it's slower absorbed, then that can actually progress over time. And so what might happen is people think, oh, I've got a little bit of asthma, and they've just eaten the food. And that's actually a really big red flag. And when I say red flag, I mean the adrenaline should be used straight away if you have asthma after a food allergy, because then it can develop and it can keep getting worse and worse. And then eventually it might be too late to use the adrenaline because it's just progressed, because more of that food gets absorbed and it just keeps going.
What are the symptoms of asthma and anaphylaxis that can mirror each other?
Yeah, so often when a kid has a food allergy, the first thing I hear is that they start coughing, and sometimes it's just a throat clearing, and it seems like they just can't stop. They just cough, cough, cough. That's when I start to think, oh, this isn't good. And then so that could be asthma as well. But I know when this is happening that the person has just eaten the food that we are thinking they're allergic to. And so that's where, if they've got a known food allergy and they eat some food and they start coughing, that's not asthma anymore. That's anaphylaxis.
That's anaphylaxis.
Yeah. Whereas if someone's going for a run or running around at sport and they start coughing and they haven't had any food, then you think, well, that's asthma.
Sure. So is there a particular order then you should be administering the adrenaline via an EpiPen or Ventolin for treatment?
Yeah, absolutely. If someone has known food allergy and they're getting a cough, never go to Ventolin first, always go to adrenaline, because what it's showing is that they've started to have a reaction, and that is what we call a systemic reaction, so a whole body reaction. So obviously the lungs are separate from the gut and the food's gone into the gut. So we know that it's gone through the whole body and the whole body is having a reaction, and they should get adrenaline straight away. And sometimes that's where having an action plan to really line this out and draw people's attention to the fact that symptoms of asthma indicate a severe reaction and adrenaline should be used can be quite helpful. And so that's why, if it's carried in a file or on their MedicAlert, if they carry it with them, all they need to do is look at that and go, okay, I shouldn't double think this. It's probably anaphylaxis because I've had food and now I'm getting asthma symptoms. I need my adrenaline.
And I wanted to touch on more about EpiPens and the administration of adrenaline, because I know that even through our series that we've been doing, a lot of people don't know about the correct administration or when you should be administering an EpiPen. So what do you think the biggest mistake is when people are having to administer an EpiPen or auto-injector?
Good question. Well, I think the biggest mistake is not giving it in time.
Right.
But then when you go to giving it, people don't always know how to give it, and they don't necessarily know where to give it. But I think that's less common. So I'll go back on how to correct that. So as I said before, if they're having an asthma attack and that's directly after eating food, that means it's anaphylaxis, even if they don't have a rash. And so they should give the EpiPen or adrenaline at that point. So that's the first mistake, the biggest mistake. Often people won't carry it with them. Often they're too scared to give it because if they think, oh, it's probably just asthma, it's okay. And some people are too scared to give it because it means they have to go to hospital.
So is that when you administer adrenaline, you have to be hospitalized afterwards or at least be checked up?
Yeah, we do recommend that because one dose of adrenaline might be helpful, but then you might need more. And even if it completely goes away, it could technically bounce back and you get worse again. So we always recommend go to hospital straight after giving the adrenaline. And I don't mind if you're bored there, because if you're bored there, that means I've done my job. That means you're safe.
And then from your perspective, what EpiPen related information is probably most important to have on someone's MedicAlert file?
So I think that's where having that action plan is really useful so that people know when to give it, so that they can look through it. They don't have to second guess themselves, just look at the instructions. It says, okay, they're having an asthma attack, right, we have to give it. Because asthma attack after food is not asthma, it's anaphylaxis. Paperwork helps you know when to give the adrenaline, and then the paperwork it's as well shows how to give the adrenaline.
So it's very specific.
That's it.
And then we touched on before that allergies can change over time. Is there anything that MedicAlert does to make sure that that information can stay up to date with any changes?
So the MedicAlert online profile is easy to update. You can send in a new action plan, and that might have said something like eggs, milk, and nuts. And then obviously, if you're now only allergic to nuts and you can have eggs and milk, then you can update that action plan to say now you're okay with that. You can also, if you've outgrown all those allergies and maybe you're only left with asthma, you can remove the action plan for anaphylaxis from your record and just put your asthma action plan instead. And as I said, you'd expect never to be getting asthma after food. It'd probably be might get asthma after a cold, or you might get asthma after exercise. And then the action plan you can carry with you on your MedicAlert, and that says how to manage that. That might be giving some further Ventolin or changing your preventer and increasing how much you give.
Amazing. So it's really easy to do that.
Yeah, you just put your new action plan online. You can take a photo of it, upload it, and then you don't have to make photocopies or anything like that. You don't have to fax it anywhere. You just put it on.
It's just all together.
That's it. Yeah. Access that through your QR code.
And talking a little bit more about that QR code technology, how was that used with a MedicAlert?
So MedicAlert's got the IDs. So that's around the wrist, around the neck, or on the shoes. And so you have the ID, and that has the little words on it. So the engraving itself, that might say anaphylaxis peanuts or food anaphylaxis. But there's also that QR code there as well. And that QR code can be scanned with anything that can read a QR code, like your smartphones. And that will open up their profile. And on that profile, it'll go into more detail. So that's where if someone says food anaphylaxis and then you open it up, then you'll be able to see which foods, you'll be able to see what the action plan is on their MedicAlert record. And now we've got a new member card, then we can actually tap the member cards, the new member cards that are available, to bring up that same profile.
Wow, so it'll be a little bit, I guess, like a credit card, that same tap.
Yeah, that's right.
Technology.
Yeah, so it's called an NFC reader. So the phones all come with that. And so basically you put your phone up to the MedicAlert card, and then it'll say, do you want to open this website? So you click on that, and then you open it up and you can see that same record.
Wow, and I think that's so helpful for people that might not necessarily understand what a lot of the abbreviations on the MedicAlert are. I think sometimes that might be a little bit more catered to those healthcare professionals that might be potentially looking at it. So I think just from a bystander perspective, or if you're a family member, having that information so readily available will just be so beneficial.
Yeah, and I think as a bystander or a first aider or something, it's important to know that people who have medical alerts have deliberately put stuff on there for you to look at. So none of it is confidential. I mean, it's private information, but if they need your help in an emergency, then they want you to look at the information they've put on there. So no one should feel worried about accessing it. And if they don't understand those little letters on there and they want to understand how they can help, then often tapping or scanning the QR code means that they can then access those documents like the action plan and the important information, the next of kin, all of that kind of thing, so that they know what to do and they can understand how they can help.
Sure. And if there's anyone thinking about getting a MedicAlert, or perhaps they know someone that might benefit from one, what's the best way that they can go about organizing one? Is it to go to their GP or to call us?
Yeah, so it really depends on how you like to talk to people. So a lot of people will like to do things online. They'll like to do it in the evening after work. So online is the best way there. You choose the ID and then write in the conditions that you have that you're most interested in putting on your MedicAlert, and then submit. And then our team will have a look at it and make sure they understand what the highest priority is, because we want to make sure we get the most critical information first to first responders.
So what kind of information is that?
Yeah, so we've actually got a list of highest priority conditions. So first up, if someone had a drug allergy, so that means if they're allergic to a medicine.
Sure.
So if someone's unconscious or confused and they have anaphylaxis and they have a known anaphylaxis to an antibiotic, the last thing you want is, as a doctor, to give them that antibiotic and make them worse. So that's one of the highest priority things. Another is if people can't have oxygen. There's a few people who've had certain chemotherapy and you don't want to give them high flow oxygen because that can damage their lungs further. And there are some people with emphysema who can't have high flow oxygen as well, because that will actually stop them breathing. So that kind of information is very critical. And then we have other critical information, which is some of those conditions that might change treatment. So some of those are something like hereditary angioedema. And so hereditary angioedema is a condition where somebody develops swelling, and that could be in their throat or on their lips or in their gut. But if it's in their throat, they can't speak, it makes them unconscious, and someone might think, oh, this person's having anaphylaxis, but they don't treat with adrenaline. So if somebody has that and then they're collapsed, and the fact that they've got hereditary angioedema would be written on their MedicAlert, so the health responders, first responders, would know how to manage them straight away.
So is there a particular hierarchy that we use?
Yeah, we've developed one in MedicAlert. I got the help from other doctors and ambulance officers and paramedics and pharmacists to help understand what the most important things would be in an emergency and what needs to be really shouted out. So the things that we've highlighted are something like, if someone has an advanced care directive, we think that's very important, particularly if they've got a do not resuscitate order, if they don't want to be intubated, then that's really important for people, for emergency doctors or ambulance officers who are looking at them on the ground, or maybe they're struggling to breathe. If they've declared, I don't want anyone to put a tube down my throat if I'm having trouble breathing, and often that would be because someone's got very late stage emphysema.
Oh, sure.
So somebody with late stage emphysema is very unlikely to survive if they have a tube put down their throat, if they're that sick and they need a tube. So what ends up happening is it's better to decide in advance, all right? I'm happy to have antibiotics. I'm happy to have lots of oxygen. I'm happy to have some different breathing apparatus, but I do not want a tube down my throat or into my lungs to keep me breathing.
Which is very understandable.
That's it. So, and they don't want to go to ICU. And so that's the kind of thing that we need to alert emergency responders to if someone's had that and they've declared that, so that it can be avoided. So that's one thing, so advanced care directives. And then we've also got, as I said, the severe life-threatening drug reactions. So if they're allergic to something like a penicillin, and I know of a patient who had a penicillin anaphylaxis and then he forgot about it and then he had an injury on a football field.
Oh no.
And he broke one of his bones, and he probably would have remembered if it wasn't such a stressful situation, but on the way to the hospital he had some Penthrain and then they gave him some opioids to try and help his pain. But when he was asked, oh, do you have any allergies? It's not a question he was used to answering. So he said, no, I'm fine. And then in the surgery, unfortunately, he had anaphylaxis.
Oh no.
The good thing is he didn't pass away.
Okay.
They were able to treat it, but it did mean that they were unable to complete the surgery at that point. They had to take him off to ICU, and then they had to wait a whole nother day to do the surgery.
Wow. And that's even in, a healthcare setting.
That's it, yeah. So even not knowing in that instant, it still had a bad outcome, not as bad as it could have been, but if he'd had a MedicAlert that said anaphylaxis penicillin, it's very simple to switch out which antibiotic they use. But people expect that they'll be able to remember these things, and it's not always the case.
No, and when you're in shock and
Exactly.
that kind of thing, sometimes that's the last thing you're thinking about.
That's it. And you don't see it as an identity, you don't think, I'm a person with this allergy. That's not who you are. He's off playing sport and he's having a good time. He's not thinking, I have to remember my penicillin allergy. So it makes sense that it's not something that comes to your mind first up. So going back to the other high priority things, something like somebody with epilepsy is very important. Now, there's a few reasons. One, obviously, because they could be having a seizure, but the other is because after a seizure, do you know what happens to someone after a seizure?
No, I don't know.
So when they're coming to, their brain has basically been electrocuted, and all the wiring is not quite connected again. So when they're coming to, they get this phase called a post-ictal phase. They walk around, but they look drunk or confused and might walk into somebody else's house. And I know a patient who tried to go to his grandma's house, but in fact he was walking into somebody else's house and he got arrested by the police and he didn't know what was going on. He couldn't quite understand.
And especially, I guess, if it's mimicking sometimes the symptoms of intoxication, then that wouldn't help the situation at all.
That's it. And so I think if somebody or if your family member has epilepsy and you know that they're sort of leaving you, I sort of think if my children ever had it, I would hate for them to be judged as someone who's just drunk, like a drunk teenager or doing something naughty and inappropriate and then being arrested and not understanding what was going on. And so having this kind of ID on could show, yes, this person has epilepsy. Hang on a minute. Maybe that's why they're looking drunk and confused. Maybe that's why they're walking into someone else's house, and can explain what next to do. So instead of being arrested and getting taken off, you could phone their next of kin who could come and get them, and
And then
be
it
much
would just be
happier.
much simpler.
That's
Yes.
right. Saves everybody's time and trauma. Yeah. There's a few other things that might need different kind of treatment. So for somebody with Addison's disease or adrenal insufficiency, if they have an episode, then they can look like they've got gastroenteritis. But in fact, so they'll be vomiting and they'll have a low blood pressure. But in fact, they need replacement of that hormone that they're missing. And so
And
it's
is
actually,
that something that's tricky to be diagnosed in the first place?
yeah, they would have had to go through some different diagnostic workups to understand that that's been the cause of their problems. But once it's been diagnosed, the last thing you want is to have to repeat that experience.
Oh, of course.
And some people might see them and think, oh, they've got gastro, let's just leave them, they can just rehydrate on their own. But they'll need this hormone, otherwise they won't be able to continue. So that is a very specific sort of treatment that can look like something much less severe.
But where the treatment really matters.
Exactly, yeah. And their plan and the exact dose of medication can be written on their MedicAlert that they carry with them so that people can understand. And they might even be holding it with them. A lot of people will carry their treatments with them so that they can be treated immediately in an emergency, and they might go beyond the ability to treat themselves, and so they'll need someone else to do that. And that whether they're able to at least point to their MedicAlert so that they can show people, oh, this is where to find the information, or you would hope that people would look at it themselves and see the instructions and know what to do.
I know what to do, of course.
Yeah.
Is there anything else part of that hierarchy?
Yeah, so another high priority thing we've got on our list is for Jehovah's Witnesses who've signed
the blood.
That's right. So these people might have signed something with and gone through lots of detailed assessment about what kind of products they have, what kind of products they won't have, and the best thing for them to do is to carry that document with them. But it might be several pages long and you don't know when you might need a blood transfusion. So having that on their MedicAlert can be really useful. And it's not just useful for the person, it's very useful for the doctor as well, because they want to give the right treatment for the person and make sure that they let that person continue to live by their values.
And that's something even I didn't consider because, I mean, you think of the medical conditions, but for people's personal beliefs and religious sort of aspects, it's so important for medical decisions that their wishes are being upheld.
Yeah, exactly. And we believe that MedicAlert can be a very useful tool for people who are culturally diverse as well and linguistically diverse. Obviously, that language barrier is there. And so should they not understand or not be able to use the same medical language, even if they don't have any problem speaking English, they might not be able to say, oh, I've got adrenal insufficiency or
Yes, the exact,
myocardial
very
infarction.
specific terminology.
Exactly. And, there's probably many other English speaking people who can't say the medical words. And so helping people to be able to actually articulate what they've got and explain that to doctors or emergency clinicians at the time is so important. A few other things are a few specific medications. So insulin is one that I alluded to earlier. So if someone's on insulin and they're a diabetic, then they are at risk of low blood sugars. And so low blood sugars can make you collapse, can make you, again, seem like a drunk. And you don't want people arresting a diabetic with a low blood sugar.
No, especially when they then can't communicate that they are suffering from a low blood sugar episode.
That's it. And they might just leave them and to do their own thing, but they actually need that. They need sugar or like glucose to help them revive, and they might even need a longer stay in hospital to make that more stable. And then things like blood thinners. So the typical one was warfarin, or other names are like apixaban, and clexane. So there's strong blood thinners, also known as anticoagulants, which mean that if you have a fall and you hit your head, or if you've got severe abdominal pain and you're on these blood thinners, then you might have some more bleeding than you'd expect. So they are more likely to need to go to hospital to get checked out. But if they did have a bleed in the brain and they started to have some difficulty speaking, it's really important that that blood thinner is reversed before they go into surgery so that they don't,
of course,
bleed too much.
bleed too much.
That's it. And that they can stop the bleed when it's in there. So you don't want to compromise the brain. You want to get rid of the bleeding that's in there, but you've got to stop the anticoagulant and you've got to make sure that you've got normal clotting when you do the procedure. There are other things that we talk about, such as pacemakers and insulin pumps, that are important to notify people of. If you've got an insulin pump, then obviously that insulin's going to be going into the blood system.
Yes.
And if you don't turn it off, then your sugar's going to be going lower and lower, even if you're not eating.
And one that I've just thought of is that, say someone's had a hip replacement or they have any metal within their body that they've had placed, then for MRIs, our medical scans, can that be another use that we have on that hierarchy?
Yeah, absolutely. So if someone has a pacemaker, then they can't have the MRI, or any sort of metal, then they should notify the MRI people before they have an MRI, because you don't want to break the machine and then the MRI won't work as well.
No, and then I guess if someone's unconscious and they can't explain that they are unable to have an MRI, that's another.
Exactly, yeah. So very important to notify people of that.
Definitely.
So what I've got lower on the hierarchy, but it's still very important, is what someone's on every day as their usual medications. So something like, I talked about beta blockers before.
Yes.
That can counteract adrenaline, and anything that might stop your heart going into funny rhythms. But really, any medication can interact with other medication. And so it's really useful to know all the things that somebody's on, because that might mean it might have contributed to why they're in a certain situation. Like some medications can cause low salt levels, and sometimes patients will take too many. And so, like, it really helps us understand the whole picture. And I kind of think about the background history and the medication as really painting in the back of a portrait. So you see the person, you see why they're there on that day. That might be something to do with their heart, it might be something to do with their lungs. But understanding all about the rest of the person, that includes cultural things, stresses in their life, and what their preferences are. But their medications and the conditions that have ever happened to them before can really help you paint a picture of what's going on and how you can treat them. Like I say to people, well, if I tell you that I might happen to come across a person lying on the ground who's screaming in agony and they're holding their chest, and they've got severe chest pain, and then I tell you that that person's 5 and their sister's standing next to them after looking a bit smug because she's kicked them in the chest because he stole their toy or something. So the context is so important.
Yes, definitely.
So at first, when I tell the story, people think, oh, this person must be having a heart attack, or they might be struggling to breathe. But when you put the background information, and from the doctor's perspective, that's the medication and the conditions, and that kind of tells a different story, completely different story.
Yes, definitely.
Yeah.
So I'd like to wrap our first episode with one final question. If someone is listening today and thinking, I'm not sure if this applies to me or someone that they know, what's the one thing you want them to take away from this episode?
I like to put that back to people and ask them, what what is their plan for should an emergency arise? Like, what do they expect to happen? How do they think they'll manage? Like, will they remember all their medications? Will they know what to do? And it really doesn't matter what's happening to you, like who you are, whether you've got medications, whether you've got an allergy. If you have a think about if something terrible happened to me, like a car accident, and I couldn't speak and I couldn't remember my family member's phone number, what would you wish you could tell people? Would there be something? Is there something that you think, oh, I'd really like people to know this? Do you think that you'd be able to remember everything you need to remember? And just have a think about that. And I like to tell people, well, you make a plan for how that's going to work for you. And maybe that involves MedicAlert. And maybe that can make you feel a little bit more confident.
Amazing. Well, thank you so much for taking time out of your incredibly busy schedule to talk with me. I've learnt so much, even just sitting here interviewing you for this episode. So I have no doubt that our listeners will have gained so much valuable information.
Thank you.
All right, it's just me again, Annie, popping back in after the interview. If you found yourself thinking that a MedicAlert might be helpful for you or someone you know while listening, everything you need is in the show notes, including where to find more information and how to get in touch with the MedicAlert team. If you have any podcast questions you'd like answered or topics you'd love us to explore, the marketing team would love to hear from you. Those details are in the show notes too. Thank you for listening to episode 1 of MedicAlert Moments That Matter. If you found this podcast helpful or even just interesting to listen to, please follow the show or share it with others. I am so excited to introduce you to even more brilliant guests with a wealth of knowledge in the episodes to come. This podcast was written, hosted, and produced by me, Anneliese Pittman, with support from MedicAlert Foundation Australia. And of course, thank you again to Dr. Caroline Foreman for being our first guest. Until next time.